Hello. In this video, we shall discuss cholelithiasis, also known as gallstones. We shall talk about the pathophysiology as well as the clinical manifestations. But first, let's do a short recap of the anatomy of the gallbladder. The gallbladder is a hollow organ that sits under the liver. In adults, the gallbladder measures approximately 8 centimeters in length and 4 centimeters in diameter when fully distended. The gallbladder is divided into 3 sections. We have the fundus, we have the body, and then the neck. As you may already know, bile is manufactured in the liver and stored in the gallbladder for easy access into the small intestine through the common bile ducts. This part is called the cystic duct. The cystic duct joins the common hepatic duct to form the common bile duct, from which bile enters into the duodenum. This part is called the sphincter of Oddi. Now, this sphincter is located at a point where the bile ducts and the pancreatic ducts connect to the duodenum. So let's say you have just eaten some fatty food, like maybe French fries. The digestive process starts right from your mouth. So by the time the French fries gets through your stomach into the small intestine, it is not really French fries anymore. However, due to the high fat content, it makes it quite difficult to be absorbed, and that is when the gallbladder steps in to help. The high fat content actually causes a peptide hormone called cholecystokinin to stimulate your gallbladder to contract and supply a little amount of bile to help with the absorption of fat. That bile then travels from the gallbladder into the small intestine to mix up and package the fat so it can be absorbed easily. This short process of mixing and packaging of the bile in the small intestine is called emulsification. Now let's focus on the bile for a minute and see what it is actually made of. So a majority or a major component of the bile is made up of bile salts and bile acids. That is approximately 70% of the total composition. 15% is made up of cholesterol and phospholipids, and about 5% is made up of proteins. Interestingly, only 1% is bilirubin, and there are other components like electrolytes, water, and bicarbonates. So bile salts and acids are mainly a product of cholesterol metabolism. The acid looks something like this, and the salt, which is the anionic form, would look something like that. As you may recognize, both the acid and its salt have the hydrophobic and hydrophilic parts. So this makes them amphiphilic. So it means that they do not hate water and they do not like it either. But actually, this enables them to make cholesterol and fat more soluble in the bile when it gets into the small intestine. Now, phospholipids are also amphiphilic. Therefore, they help to make cholesterol more soluble and packageable and ready to be absorbed. Now, let's focus on gallstones and how they are formed. So, gallstones are usually round and come in a few varieties, and we can classify them based on their color and components. Some are yellow, others are brown, and some are even black. The yellow ones are called cholesterol stones, and they are the most common among the three. They are formed when cholesterol are able to precipitate out of the solution of the bile and become stones or becomes hardened in the process. Now, the black stones are most commonly called pigmented stone because they are made of bilirubin. We will talk about the brownish stones later, but in the meantime, let's focus on how the cholesterol stones are formed. Now, the process by which cholesterol moves out of the solution of bile is called precipitation. Precipitation of cholesterol can happen in 3 main ways. So in the first instance, bile can become highly saturated with cholesterol to the extent that the bile salts, the bile acids, as well as the phospholipids are unable to hold any more cholesterol in the solution. So even though these components are there to dissolve the cholesterol, they become overwhelmed in this scenario. So what then happens? The excess cholesterol will then feel redundant and will decide to move out of the solution and then turn into stones in the process. Now, in the second instance, there isn't enough production of bile acids. Bile salts are also lacking, and phospholipids are deficient in the solution. Deficiency in bile salts can be as a result of Crohn's disease or after gut resection, or even as a result of fasting when there is prolonged sequestration of bile salts in the gallbladder. So as you may have guessed, in this second scenario, there won't be enough resources, namely the bile acid, the bile salts, and the phospholipids, to hold the cholesterol in the solution. Therefore, the cholesterol will move out of the solution and turn into stones. Now, in the third instance, this happens where there is too much bile secretion and there is too much bile being stored in the gallbladder and not used often. So in this case, there's going to be stasis or piling up of bile in the gallbladder, which will then lead to the formation of cholesterol stones. Now, somewhere at the beginning, we mentioned that bile is originally composed of some amounts of carbon and electrolytes like calcium. In the process of precipitation of cholesterol, if calcium binds to carbonates, we get calcium carbonate. Now, this compound is radio-opaque, meaning that it can be seen on an X-ray. Cholesterol stones are commonly mixed with other stuff, including calcium carbonate. But the stone is not visible on an X-ray because calcium carbonate makes up just a tiny proportion of the cholesterol stones. Now let's look at the black pigmented stone or bilirubin stones. This is usually formed when there is too much bilirubin in the bile, which then mixed with the calcium. So the mixture of bilirubin with calcium will give us calcium bilirubinate. This type of stone, that is the bilirubin stone, can be seen on an X-ray. This is because calcium makes up about 50% of the composition of this stone, and therefore, since calcium is really opaque, then the stone is going to be seen on an X-ray. Now, brown stones or brown pigmented stones are usually a sign of infection, and in most cases, these stones are able to move from the gallbladder into the bile duct. Brown stones can be formed from a combination of deconjugated or unconjugated bilirubin and calcium. So let's see what exactly happened here. A bacteria, for example, E. coli, will cause gallbladder infection, which would then lead to the release of hydrolytic enzymes, particularly beta-glucosidase. Now, these hydrolytic enzymes will go ahead to hydrolyze already conjugated bilirubin and phospholipids. The bilirubin then becomes deconjugated and then moves out together with phospholipids to mix with the calcium ions. Now, the mixture will then harden to form a stone, that is the brown stone. And this brown stone gets its color from the hydrolyzed bilirubin and phospholipids. Now, in general terms, women are more at risk of developing gallstones than men because estrogen, unfortunately, increases cholesterol stone formation. Also, the use of oral contraceptives that contain estrogen is another risk factor. Obesity is another common risk factor of developing cholesterol stones. Now, black pigmented stones or bilirubin stones are seen in persons with hemolytic disease, for example, sickle cell disease. It can also be seen in some cases of liver cirrhosis. Gallstones are most often asymptomatic and are sometimes discovered incidentally at autopsy or during surgery for an unrelated condition. Among patients that develop symptoms from gallstones, the symptoms can range from mild nausea or abdominal discomfort after eating fatty or fried foods to severe symptoms like right upper quadrant or mid-epigastric abdominal pain, as well as jaundice in some cases. When the cystic duct or the common bile duct is transiently blocked by a stone, pressure rises in the bile ducts. Now, the resultant increase in peristaltic contraction in this area will then cause severe visceral pain in the epigastric area, and this pain can sometimes irradiate to the back. A major clinical presentation of gallstone is inflammation of the gallbladder, which is known as cholecystitis. Now, cholecystitis can either be acute or chronic. An acute episode of cholecystitis can eventually progress into acute pancreatitis. This may happen when a stone travels down the common bile duct, but then fails to clear from the sphincter of Oddi and thereby blocking the pancreatic duct. Likewise, an inflamed gallbladder can undergo infarction and necrosis. Now, at this stage, this is already an advanced stage, and that could easily lead to a case of systemic sepsis if the patient does not receive systemic broad-spectrum antibiotics and undergo emergency cholecystectomy or removal of the gallbladder. Thanks for watching.